Thank you very much. Thank you also for these two great presentations. I have our center in the United States was the first one in the United States to use TTFM. And I have to tell you that since we started to use that in the United States, I have basically insisted on using this type of technology on every single coronary artery bypass graft I have been doing since that time, whether it is in United States, in Bosnia or elsewhere. And I want to try to convince you here today that why I think that is very good reason to do that, and why I think that we should use that, and combining the two methods that we are talking about here today. As you know, coronary artery surgery results in general are good. They are strictly monitored in many locations around the world. Mortality is maybe between 1% and 3%, sometimes higher. But there are significant numbers of complications, especially myocardial infarction, stroke, and also infection. These are some of the most serious complications that we encounter as cardiac surgeons and that are causing major problems for us. I want to also talk about something else, that in the United States it's estimated that there are 150,000 deaths from surgery. This is all types of surgery. And that 50% of those deaths are avoidable. I will dare to say that in cardiac surgery, a number of deaths are avoidable, and maybe that this type of technology should be included in the checklist. I have a book that I will recommend to you all to read. I will show you the front of it in a second. But acceptance of errors in medicine is about 3 to 5% of medical errors in general. In the airline industry, it's about 1 to 1 million. If airline industry accepted the same failure rate as we accepted medicine, there would be 200 airplane crashes every day. It's something to think about. And I think that some of the crashes we see, we also talk about crashes in the operating room, for example. Some of those crashes are due to lack of using technology that is available. This book by Atul Gawande, I just finished it. It's talking about this checklist manifesto. This checklist in surgery is something that is being pushed very strongly now by World Health Organization, and is slowly getting into surgical services. But the point is that you should check certain things according to an airplane pilot type of methodology. And I think that both ultrasound, epi-aortic ultrasound, and TTFM should be included as part of that checklist. So how do we improve the results in the individual patient that we deal with every day as cardiac surgeons? Well, of course, we think about individual patients, but we are also subject to quality assurance in our institutions, and the main issues are the early issues are death, of course, myocardial infarction, stroke, and infection. I will not talk about infection anymore. And then the late complications, death, MACEs, and reinterventions. All these things are issues that are important for our patients. And of course, I worked in New York State for more than 20 years as a cardiac surgeon. And we were also very much concerned about this report that came out every couple of years, where the mortality of each center, here all the centers in New York State, and also each surgeon were published on the internet, and we could see if you were good, average or bad directly on the internet. So there's a lot of discussion about these type of things, but I think that certainly for each of us, we want to have the best possible results. So what does it happen when you get a complication after cardiac surgery? And all cardiac surgeons know that, so I'm not telling you anything new. But if you get the cardiac complication after cardiac surgery, for example, infarction, the death rate is 18.6%. If you get the stroke, the mortality is here, almost 20% mortality. And these are the things that I will talk about a little bit more. Another study from North Carolina, again, cardiac, if you have cardiac complication, mortality rate is 8% and neurological 23%. So complication very frequently result in death. Well, how we tried to deal with this back in mid-90s was in Buffalo was that we went to cardiopulmonary bypass without a pump, off pump, and we have published quite extensively on that. And we looked at this on pump, off pump, and we found that if we used the off pump technique, at least in this non-randomized study, we could reduce the stroke rate and infarct and so forth. This, of course, is now a tremendous literature on this topic, off pump and on pump. I'm not going to talk too much more about that. But when we come to the daily case that we are doing in surgery, when we start our cardiac surgery case, then first question is sometimes where is the vessel and where should I graft it? I must say that one of the first deaths I ever had in my whole career, I worked at the Veterans Administration Hospital in Buffalo, and I lost one patient. It was a disaster for me personally. You know, the first death is, but that was a patient where I couldn't find the LAD. And I think every cardiac surgeon has had that type of experience. You cannot find the LAD, and I couldn't find the LAD. Finally, I found it, but in the meantime, there was so much problems that eventually the patient died from myocardial damage. And then I think that. Now this is just a regular coronary angiogram, and most of the time you can find the vessels quite easily, but sometimes you can't. And then this, to find the vessel using an epicardial ultrasound can be very helpful. And this is demonstrated in this article from Cincinnati and Virginia, published in Annals of Thoracic Surgery, that you can find the vessels using epicardial ultrasound, and we have used that routinely after we got this device, with good help. And you know, I think that both some of the other speakers have better pictures than we have, but this is just one of the some pictures we have. You demonstrate the LAD. You can also find the LAD, and then also you can look at the vessel. Sometimes angiogram is not clear. Is the vessel graftable in that spot or not? And you go to you can look at the vessel. You can see that if a plaque is purely a plaque, or if there is a bad disease inside, like here, and then it can help you to guide where do you put the bypass graft instead of opening sometimes blindly. Just another example of a normal vessel with flow in it, normal LAD. So then the question is, when you are at that stage, just when you open the chest, of course, say, how should I do this operation? And then we come to the status of the ascending aorta, and I think that the previous presentations showed clearly the value that this can have. And then you said, well, maybe I should do op cab with this, or should I do on cab? Or maybe I should even use no-touch technique and use only arterial grafts not to touch the aorta at all if you have an old patient with an aorta like Dr. Kemmler just showed.